Dr. John McClaren, welcome back to Life After Impact.
It is always a pleasure to be here. Thank you so much.
Yes, well, always a pleasure to talk to you and pick your brain. So, we were just talking off air, and you made the comment that it seems like these days everybody coming into your office seems to have dysautonomia. So let's start there.
Absolutely. That's the thing. We look at parcellating our diagnostics into subtypes, right? You go, I've got a vestibular concussion, or I've got a concussion that is oculomotor, or I've got a concussion that is mood based or limbic or brain fog or things like that. And one of the linkages in all of these is that they've got fuel delivery issues, which is what the autonomic system is one of the things it's ultimately responsible for. Everybody's got some kind of orthostatic issue where, I get, I bend over to pick up a basket of clothes and I get dizzy when I stand up, or I can't change the water in the fountain or something like that without getting dizzy, or I can't look up and grab, the top shelf thing without getting dizzy. These people have this stuff, and it's after they've had some kind of a traumatic brain injury or, some of these long COVID types things and Lyme and all those things we see. Uh, it's out there because people just seem like they're so much more inflamed in general these days, so they're more
Yeah,
predisposed to maybe having it.
the thing of I bend forward and then I stand back up and I get dizzy, I hear that all the time.
So much of
And
that.
or, I'm putting my clothes from the washing machine into the dryer and just
Yeah,
making that movement makes me dizzy. I hear that a lot too.
yeah.
And so you're really seeing kind of this increase in dysautonomia that you think is maybe in part due to just general levels of inflammation being higher in our population.
I feel like it. It's interesting in the last, well, let's see, 6 years, for some reason, there's a lot more of that out there, and the world is just what it is. You see so much more mold sensitivity. I think in all of our practices who do functional neurology, we're seeing everybody's got a mold issue now, or if people had Lyme, it seems like it's worse, these kind of things, or the dietary things are maybe a little more sensitive than they used to be, so it's like, gosh, I have to be really more deliberate on my diet than I used to be okay. The gut's
Right.
inflamed, whatever it is. Yeah.
Yeah, and I think that it I think it's frustrating for people because from my perspective, I feel like it is harder and harder to live in this world and live in the environment that we
Mhm.
live in and maintain health. You have to be aware of everything from, oh, are my dish pods coating my dishes in microplastics? Am
There's
I
so
breathing?
much.
There's so much. Like, am I
Yes.
breathing in chemicals? How much glyphosate am I eating in my diet? It's like we have to be aware of what are we drinking, what are we eating, what do we have in our household,
Yeah.
where do we live, what kind of air pollution are we breathing in, and it just like I agree. I think we are all walking around more inflamed, but I also think it's because of our environment, is what
Huge.
makes me a little frustrated because then it's like, well, how do we fix the world if it's the actual environment that's making us more inflamed?
Absolutely, and is there incentive in society to do that and all these kind of things? But that's the problem too, is now a lot of us know this stuff too. It's so much more information out there. You hear on almost every show now, "Oh, you've got 4 or 5 bottle caps worth of plastic in your brain," and all this stuff, and now I'm hyper vigilant about it, which is always great for your stress state too. So now I'm stressed out about not being healthy and of course, you wanna go out to eat, not so easy, and seed oils are something a lot of people are really concerned about too, and, so then what do you
Yeah.
do? It's like, it's very difficult to navigate the world, absolutely, and that's where we talked a little bit about, people use artificial intelligence to kinda try and guide their decisions, and the problem with that is who's writing the language for the searches and how much does it learn you and how much does it kind of feed what you're already doing and those kind of things. And that's where you need people who have the clinical background, the training. I'm Carrick trained. I will say that again until I'm on my grave. It'll go on my gravestone, probably hashtag Carrick trained. The character trained people are the best, in my opinion, in the world at helping people ferret out this information.
Well, I think that we are trained to constantly be reading the research and to be paying attention to the research because when it comes to the brain and neuroscience, that whole field is advancing so quickly that what you learned 2 years ago is already outdated. And I'm getting ready to teach a Parkinson's class in 2 months. And I was going through my slides from a Parkinson's course. I presented at ISCN, the International Symposium of Clinical Neuroscience in
Yeah.
2017, and I presented a Parkinson's case. And so I had my slides from 2017. I had to double the numbers on my slides because
Wow.
I pulled all the epidemiological reports, right? And I'm looking at the numbers, and the amount of Parkinson's has basically doubled since 2017, since I had my PowerPoint slides from then.
Wow.
And I gotta tell you, it was really just this sad moment of, like, having to update my slides. It was sad. I got
It's
sad.
unfortunate, isn't it? You hear that and you go and I would imagine one of the other things you saw in that was the age range really widening, younger and younger people getting it. It's unfortunate, and then you go, "Well, what has changed? Is it the human brain or is it the world that the human brain surrounded it?"
Right.
Yeah,
And so, I mean, not to get too off topic and talk about Parkinson's, but, the FDA finally did ban trichloroethylene,
yeah,
and it was because of all of the soldiers at Camp Lejeune and all the data that came out of that said, everybody got exposed to this chemical in the drinking water there for a certain time frame until they discovered it, and basically those people, like 70% of them went on to get Parkinson's.
it's just terrible.
It's terrible, and the data was just you couldn't refute it. It was so clear, and so
Right.
finally they said, "Okay, clearly we need to ban this, but we it's also gonna take us about 5 years to, like, regulate that ban," and so, it's gonna take a while, but it just goes to show you that I think glyphosate is also the perfect example of this,
Yeah,
where, they just passed a law that said that the people who manufacture chemicals containing glyphosate are now immune from any
yeah.
prosecution, almost saying, "Okay, we know that it's going to come out that this causes lymphoma and cancers, and so we're just going to give you all a blanket immunity so no one sues you, so that fast forward in 10 years when it's so glaringly obvious there's nothing anybody can do about it?" And so it's again, we're living in this world just feels crazy town.
But can we phase it out? That's the thing too, it's like, okay, give immunity if you have to, but phase the stuff out, and the problem is then you go, "Okay, the stuff is in the water for a reason." Maybe it's a sanitation thing or whatever it is. So you go, "Okay, I don't want listeria in my drinking water either because that's really terrible for people," or, the flesh-eating Ebola or those kind of things that could come. I don't want that stuff either, but there's gotta be a way. I just read, I got back on social media, so everything on Instagram's real, right? Some 18-year-old somewhere came up with a filter that takes 95% of microplastics out of your drinking water, and it's
Wow.
like, we can do this very well, and if you can do that, you can probably filter a lot of this other stuff out, and the filter is supposedly totally safe and non-toxic and all this stuff, so you go, "Maybe we need to talk to some of these young people who really do wanna make a difference."
So maybe there is hope that the young generations are gonna just be the inventors of making the world a safer place.
Yeah, yeah, maybe they'll take care of us, right?
We can only hope.
Stewards of the next generation, absolutely.
Yeah. Oh my gosh. Okay. Well, so switching back to this idea that we've got people with dysautonomia is becoming more common. You've discovered some patterns in your patients with dysautonomia involving what we would call maybe some deep flexor pathology.
Yes.
Explain what you mean by that. What are you finding in your exams, and how are you treating that in order to actually help these people function better?
It's really interesting. You go back through the John McClaren clinical origin story a little bit here. When I was in chiropractic college, I had a professor who taught one of our rehab classes. Jeff Rockwell is his name. He's an absolutely fabulous he was a massage therapist before he was a doctor of chiropractic, and he's one of those people who looks for different tools in his toolbox, so to speak. He's an explorer, he's a striver, one of those instructors that motivates you in a good manner, right? And he taught a lot of different things as opposed to just, "Here's the cookbook for rehab, pass your boards." He's like, "I'm gonna give you stuff that you can use in your practice," and Dr. Rockwell is one of my formative figures along with Dr. Carrick. The hands-on body work that I do, a lot of that came from things I learned from him and have integrated with the functional neurology patterns and aspects and things like that. So fast forward, there at deep neck flexor hands-on work from Dr. Rockwell way back when in the 90s. To date myself, the late 90s, right? So Dr. Rockwell teaches this deep neck flexor work and talks about it with motor vehicle accidents and post-trauma injuries because we look at a lot of times at the musculature, the back of the neck, the SCMs, the scalenes, people that dry needle do that stuff, doctors of chiropractic do that stuff, snags and all those kind of things that we've been taught through a variety of these TBI courses address that two-thirds or three-quarters of the neck musculature. You learn the cervical plexus in your professional training and then you kinda get away from it, right? It's like, well, I check the boards and off I go. Maybe I'm working with SEM or some scalene and these muscles on these big muscles that you can see that do get injured in traumatic brain injury and things like that as well. And one of the things we learned so again, this long story, right? We did the not the first TBI fellowship program through the Carrick Institute. There was the 6, series one that was kind of the second TBI program. It was the certification or something that they did at the end of that. One of the papers or a couple of the papers that they looked at in that, it centered on what's called the deep neck flexor endurance test. This is something that's rather commonly done, like athletic trainers use it to assess their athletes, especially if you've had a traumatic brain injury, concussion, post-concussion, and you've still got headaches. So they'll come in and with the deep neck flexor endurance test, you lay the patient supine, which is on their back. You pick your head up maybe a half inch off the table, kind of do a little bit of a chin tuck. So it's like give yourself a double chin as you pick your head up to really accentuate those muscles. I'm not going to give myself a double chin on air. Already there. The beard's on its way back, right? So you do this, and females should be able to hold their head for 30 seconds that way. Males for 50 seconds. We were presented the data at that time, and then there wasn't really anything we were given in that program specifically to address if we saw pathology. Fast forward a little bit, and here's how it is. I've been in practice for 24 years now. You have a lot of tools in your chest that you get away from, that you get back to, you start to see trends. And I had these post-traumatic headache patients that had dysautonomia. I had one in particular that had come in, and it was this paper was in the back of my head for some reason. And I'm looking at this guy. He's a trumpet player, high school kid, traumatic brain injury, dysautonomia. And one of the activities that was still bothering him, like, we're really close to clearing it. Eye movements are really, really pristine at this point. His postural controls are beautiful. He's got a little bit of a high resting heart rate still. That's the only real autonomic finding I've got. I'm using my reflex pupil app, which I use on my iPhone or my iPad. His pupillary data is really nice. All told, there's a little bit of fine tuning that needs to be done still, but he's still got post traumatic headaches when he plays his trumpet or
Mm.
when he does squats, which again is this orthostatic load that we talked about at the beginning. So I said, okay, what's happening here? Why do we tilt our head when we play the trumpet? He doesn't have a rotational skew or anything that I can find with my ophthalmoscopic examination. These are all things that we do. We look at breakdowns and eye movements and things like that. And I'm thinking to myself, what do I have to do to play the trumpet or to vocalize, to sing? I have to use my cricothyroid, my cricohyoid, my longus coli, and my longus capitis to fight the back pressure of the trumpet off. Or if I'm a singer, those are singing muscles. I'm very fascinated with the neurology and muscular control with singing as well.
Hmm.
So I've kinda this is one of my geeky deep dives that I'm doing is learning how people sing and vocalize. So I said, "Okay, we've gotta use this anterior musculature to fight the back pressure of a trumpet off. Let's do the deep neck flexor endurance test," which is one of the biomarkers I hadn't looked at with this patient. Like 5 seconds, he completely breaks down and gets the headache.
Wow, so you're supposed to be able to hold it for 50 seconds,
50
and he
seconds.
was able to hold it for 5 before and then
Symptom
suddenly became symptomatic.
Yeah, symptomatic, and you get this, like, ratchety ataxia too, like, you know, "How long are you gonna make me do this?" kinda thing.
Yeah.
Yeah, he gives me a look like, "Is this bad?" And it's like, "Yeah, that's pretty bad."
Wow. Mhm.
And I'm going through my thought process, and I thought, "Let's just go ahead and check the integrity of these muscles out." You get in there, you can kinda move the trachea around a little bit, and in people who've got this, you might feel some crepitus or things like that. So your biomarker, again, is the deep neck flexor endurance test and some of these autonomic things. So I get in, do some of the work with this guy, clears everything out. I can play trumpet, I don't tilt my head anymore, this, that, cool. So then naturally, what do? This is how we develop things in practice. Start looking at it more and more, and it's there all the time. This is a nice revelation in the last year that I've had.
And so was your therapy with him mostly manual work on the neck muscles?
With to clear that out for him, yeah, that's what I did. But we had done a lot of vestibular activation, a lot of oculomotor strategies, a lot of the things that you'll see in functional neurology clinics that had got him mostly really good.
Right, you'd cleared up all those other sensory
Yeah,
errors, and this was the thing that was left that was still
yeah.
driving the dysautonomia. Mm.
Yeah, and you go, "Well, what is the mechanism behind that?" Right? Well, there's a lot of mechanisms. That musculature is supplied by that cervical plexus that I talked about, which doesn't have necessarily a direct feedback into the autonomic system because it does have some aspects of vagal activation and things like that, and it was interesting to work that and see his resting heart rate come down too, which is really, really cool. That's one of those biomarkers we look at where when the autonomics aren't calibrated right, you'll see a higher resting heart rate or a lower resting heart rate than somebody should have, depending on their phenotype. Which, when I say phenotype, is how the patient presents with what they have. So it worked really well for this patient. And again, it's something I started to look at with a lot of other patients. And, some of the things that it's added to my outcomes have been really two thumbs up. So yeah, in that case, it was a lot of manual work. You could come back in and add some different neck strengthening strategies. You could make that deep neck flexor endurance test an exercise for them.
Right, because that is a very common exercise you see for, strengthening the neck is
Yeah.
is simply doing the double chin, bringing your head up off the table,
Yeah.
holding it. Yeah.
They give those in
Um,
therapy all the time. Yeah.
mhm, mhm. Well, and now you're seeing kind of way more benefits from not just strengthening the neck, but also from an autonomic perspective.
Tons of it, and it makes sense where you look at the way the nervous system's wired through the cervical and upper thoracic spine. That's where your sympathetic activation happens. We talked about in our prior discussions, there were a lot of these dysautonomia phenotypes where they didn't have proper sympathetic nervous system activation, and those are actually some of our most unstable dysautonomias out there.
Yeah. Okay. So let's talk about the airway because I also think that this is something that is huge. And I've been watching a lot of these videos on nasal release technique where they, insert like the balloon
Leaf
into the
Sockhander, yeah,
nostrils. Yeah.
yeah.
So let's talk about that. I
Well,
mean, if
and
you've been
again,
studying singing, I imagine you've been studying kind of the role of just proper airway opening, and I mean, I had a patient with a 2 concussions, and, she had, like, a double tongue tie and airway obstruction that her dentist caught,
yeah,
and so suddenly it was like we had cleaned up so many things, and the one thing that was really kind of keeping her having a lot of chronic headaches and jaw issues was just more of, like, almost orthopedic, not or orthodontic type problems with
structural
her
stuff,
jaw
yeah,
alignment, structural stuff,
yeah.
and this tongue tie and issues with her airway not being perfectly, intact and open.
Well, it's interesting when you look at that, you consider tracheal mobility and again, that cervical plexus that supplies a lot of those muscles that close and open the glottis when we do breathing versus eating and those kind of things. Again, that gets damaged. What you're getting in there doing manually is you're not necessarily, and some people will say this, like, you're not really on the cricothyroid or you're not really on the cricohyoid because they are so small and they're so deep. Again, I'm on the fascial connections in there. I'm tracing the nerve patterns. So you're doing nerve tracing techniques and things like that. Nerves, remember, just like muscles and just like blood vessels, like to be able to move. And when they don't move and they don't glide, they get inflamed, they get irritated, and they do all sorts of misbehaving, so to speak. So, what I can't do is maybe have proper mobilization of my tracheal apparatus. Now, maybe my airway isn't as efficiently functioning. And again, if I've got a perception that my airway isn't open, what am I going to do? Maybe even in a subconscious level, I'm going to change my respiration rate. When I change my respiration rate, what do? I affect my blood chemistry. So I change blood calcium, blood pH. My neurons become hyperexcitable or hypoexcitable, depending on the person. So less or more excitable. I've got an autonomic nervous system issue where I already can't fuel my brain very well. Now I take a brain that's not getting fueled. I make it really, really sensitive. Off I go.
Right. Yeah. And going back to this whole thing of I bend forward and then I come back up and I'm dizzy, it's like, well, when we bend forward, what do? Well, we're looking down too. And so we're like closing all of this off.
Tons of
And so,
activation in those muscles. Absolutely. And again, if they're
yeah.
neurologically misbehaving, so to speak,
Mhm.
you're going to get some aberrancy in that autonomic backflow and forward flow as well.
Yeah.
That's one of the factors that's very significant with us. The other thing you mentioned too, and I love how, we think we're like off topic, but we're really not, is you talked about, glyphosates and all these kind of things and microplastics and those things. Again, when we're talking about people already being a little bit inflamed, they impede what? Glymphatic and lymphatic flow. Where does the glymphatic system feed through from the brain on its way down to the subclavian vein?
The neck.
The neck, the front of the neck, especially. You've got lymph nodes in the back of the neck, but a ton of this stuff in the front of the neck. So again,
Yeah.
if I've got a kink in the hose because I'm so fascially adhered here and I've got so much mechanical restriction, and there aren't a lot of people that are doing this kind of work. There's a few out there. Um, and I think it's really, really important. And I think it's something like we've talked about writing a class for it or something like that to bring in people to do some hands-on because, it's nice to be the only guy in town that does this, but, two hands and me aren't enough for everybody, and I'm sure there are people that are better at it than I am, but it's very important. So again, now what I'm doing is I'm getting the gutters of the brain, so to speak, where you're getting that garbage removal system more efficient, less post-traumatic headache, less brain fog,
Yeah, incredible.
less inflammation, which again feeds that autonomic apparatus. If your brain's inflamed because you can't clear that stuff, that dysautonomia runs roughshod.
Right, because I know a lot of the more recent studies on the glymphatic system say that all of that metabolic waste actually drains along the vagus nerve. Like, it's actually kind of following that exact
Yeah.
same pathway.
Yep, 100%, which again, when you come in and you do your neuromodulation, and that's another thing you can do to follow up if you wanna do, "Okay, what am I gonna do? I'm gonna manually clear this." They offered the neuromodulation course back in November where herbs point, which lives right in that apparatus, is one way to activate the vagus nerve. The baroreceptors activate the vagus nerve 100%, so you can increase the efficiency of a lot of these responses by mechanically clearing that out.
Mhm. Right. And I think that speaks volumes to the ability to not only be able to perform kind of a complete functional neurological exam, but also have more of that orthopedic background,
Yeah.
manual therapy background, understanding all of it. I was just talking to Dr. Kaiser, and
Yeah.
he was kind of saying the same thing, like of that whole journey of you start out studying all this manual therapy and orthopedic structure, and then you learn the nervous system, and then you kinda go down that rabbit hole, and then you come full circle and realize it's all connected
I
and
really
it
do need
all
to use
it
my
all just
hands on my patients a little bit, yeah.
yeah, it just
Yeah.
everything plays off of each other, and you need both.
You really do, and that's the great thing where you get a lot of these patients that come in and it's like, boy, I've been to 3 or 4 medical neurologists and nothing against them, not to disparage anybody, but the frustration I hear from a lot of these dysautonomia patients is all they wanted to give me was medications, and I'm like, "I get that, that's one of the major tools in their chest," but the medications aren't super specific on how they act on that autonomic system, so you kinda get some side effects or some different profiles that can cause other problems or maybe not regulate the system properly. So when you get in and you can do some of these other things, it supplements the medicine, if not replaces it really well.
Yeah, yeah, absolutely. And then, you also mentioned that you're doing more, like, visual field therapy too lately. Talk about
Yeah.
that.
Well, and it's really interesting when you consider all of these things. What I got into a long time ago in this long COVID course that I wrote for the Carrick Institute was looking at different ways to treat people who had fragile nervous systems because long COVID is a dysautonomia along with a lot of other things. And as I got into the training and restoring smell was kind of a focus initially because a lot of people had olfaction issues. And again, as I got into my lab studies in the clinic, what I saw was a lot of the people who had anosmia or hyposmia or some olfactory changes, parosmias, olfactory hallucinations. I smell things that aren't there, like cigarette smoke and things like that, had a lot of contrast sensitivity too. There was a lot of convergence in the medial temporal cortex that processes that and the olfactory cortex, which lives somewhat in the temporal lobe as well. It's really interesting. So
And
I
so define for the audience contrast sensitivity.
so I've had a traumatic brain injury. I walk into Costco, those bright lights kill me. I'm light sensitive. I have to wear sunglasses everywhere because the light bugs my head so much.
The thing I hear is when people are driving and the sun is, like, beaming through, like, a row of pine trees, and so all of a sudden it's like, "Light dark, light dark, light
Yeah,
dark," like, it's like just
yeah.
that flicker of sunlight through the trees, and people are like, I can't do
Yeah,
it."
it overwhelms their system for sure, or
Yeah.
they maybe even have some sound sensitivity. This is where it's really starting to spread for me. I had a scholar, at the board review that I taught in March ask about sound localization with some of this stuff, and I said, "I don't know." You know, it's really interesting. There was a tonotopic maps course, and I hadn't taken it yet. Do they have disorders in sound localization was the question as well, because the auditory cortex also lives in the temporal lobe. And I said, "I don't know." And I came back into my practice, and sure enough, you know, it was a great question. I love the scholars for the Carrick Institute because they ask questions I might not have thought to ask myself. And I said, "Yeah, sure enough, they can't localize sound super well either because that's a network hub for all of those things that temporal lobe is." So, what I've done is I've looked at these people who have this contrast sensitivity. I use Focus Builder as a program to test eye movements. I love it because you can test different backgrounds with a fast eye movement or a pursued eye movement or any of these kind of things that we want to look at clinically. And you'll see plain screen people do pretty well. You change it to like a bright red background or a light bright blue background or a bright yellow background, and they just completely fall apart. They'll look at you and go, you know, these really photosensitive, light sensitive people, they'll be like, "Are you going to make me look at that screen?" Yeah, sorry. They get like limbic about it, you know, which means they're like really emotional. They know it's gonna make them feel really bad.
Yeah. Oh, at work, basically my entire wardrobe is, like, black shirts because, the few times you wear a striped shirt to work, people are like, I can't follow your thumb. You're wearing a striped shirt and the background, like, I
Yeah.
can't do it," you know? And
And
so
then you go, "Crap, does that mean I did a bad job with you?" You know, it's like, "Darn, my wardrobe choices impact my outcomes."
right? Yeah,
But
yeah.
you'll hear that all the time. People will say, I do really well when I'm in an office where there's plain white walls, but when I go to Costco or Sam's Club or whatever store it is, like, I completely fall apart." And it's the amount of visual information that comes in. It's the bright lights, the overhead, you know, the like fluorescent troffers, a lot of people will tell you, and you'll see people come in, like maybe they've been to a vision therapist and they get the red lenses or things like that because they've got that. And I'm like, that's okay. You know, that's a nice way to let this system recalibrate and calm down. But eventually, ideally, what we want to do as functional neurologists is get them to function in the world as good or maybe better than they did before their injury, hopefully when they present with you. And again, in my master's program, I looked at a lot of training on visual fields, and what a lot of people do is they'll use electronics to do like a hemifield stimulation. So you're getting a bright check screen that's off here. Sometimes that's too much for a lot of people that have this stuff, especially when the autonomic nervous system is involved. So again, back into the research, looking at what did we do before we had this stuff? And let me grab something here. It's really cool. And I give Dr. Antucci credit for this as well, is part of the assessment is to assess visual field. So you'll stand in front of the patient or behind the patient. You know, let me know when you see this thing in your peripheral vision. Let me know. And Dr. Antucci in functional neurology management of concussion takes it up a notch and he says, okay, well, the retina processes all light using three primary colors: red, green, and blue. Those are your primary retinal receptors. So what we do is we take like an Uno card, we bring it in, let me know when you see the color. What he'd seen, and in the research, is people with traumatic brain injury maybe process red differently than green, than blue. So then what do you do, right? You know what you do. So the thing I thought, again, talking analog with some of these people, is we will use that as a therapy. This is called border treatment. You train the border of the blind spot, you bring it in. So that's a nice analog application that is very palatable.
Mhm. Okay, so you're using different colored cards, red, green, blue, and you're
Yellow,
basically just and yellow, and you're kind of trying to expand someone's peripheral vision for individual colors.
perhaps. Yes.
Mhm.
And the thing that's interesting with some people that have dysautonomia, what they'll see, it'll be black or it'll be gray, and then they see the color. Or maybe if I've got an issue, it's a red card, but they see it as green, and then they see it as red.
Interesting.
So there's a breakdown in that visual processing network.
Right, yeah. One of the, optometrist that I send a lot of my patients to, he has a really cool, fancy way of assessing peripheral visual field with red, green, and blue,
Yeah,
and so he spits out those maps that kind of shows you the patient's peripheral vision with the different colors,
that's
and
cool.
so I've also heard that people with mold sensitivity seem to lose their peripheral vision more specifically with the color green. Have
Interesting.
you seen that?
I've seen a lot of that, but I've seen it vary. I haven't always seen it just with green with my mold
Mhm,
phenotypes, but it may be because I
mhm.
have other things going on.
Sure.
Interesting with that.
Yeah, yeah.
A lot of your people who have sleep wakeful disruptions, like, hey, I have a hard time getting to sleep. Blue is a lot of times what they will process improperly because blue light sets the circadian rhythm.
Interesting, yeah.
Yeah. Yeah, it's really interesting. So what I found too that was really nice is once you kind of find the color they break down on, I brought yellow in because I found people struggle with that a lot and maybe not with the others. Granted, it's not a primary color, but it's in the Uno deck already and I have it.
Okay.
Yeah,
And so essentially, you're looking at people's peripheral vision for different colors, and then also, in a sense, kind of remapping their peripheral visual field for different colors. And then we can layer in, you mentioned auditory localization, a
absolutely.
person's ability to know where sound is coming from. So I used to try to snap, and I
Yeah.
found that I'm not a very good snapper. And so one of my patients had brought like their kid had some toy and it's like a little like clacker thing. And so
Nice.
so one of my patients just like gifted my clinic this clacker.
And you go,
And so
now I
now
can do it all the time.
exactly. So now I have this child's toy that I use to test for auditory localization. But it just I guess what I'm trying to say is that it seems like when it comes to dysautonomia, when it comes to brain injuries, a big part of the therapy is helping the brain utilize all of its different maps, whether we're talking about a visual map, whether we're talking about an auditory map, whether we're talking about a joint position map of how is my body
Yeah.
positioned, and making sure that just all of these different maps are actually giving the brain accurate information. Because the second we introduce some kind of sensory error, whether it's auditory or visual or proprioceptive, then all of a sudden we have an autonomic response to that.
Yeah.
And so
Absolutely.
you're finding that by kind of cleaning up some of these visual maps with different colors and expanding someone's peripheral vision, that suddenly their autonomic system is functioning better.
Yes, absolutely, and that's the thing when you're looking at concussion and traumatic brain injury. You have a disruption in a lot of the networks that these maps regulate and are responsible with interacting in. And what'll happen is now I have to use other parts of my brain to do that can do it, that aren't so good at it, that demand more fuel. And so if we pair those networks, we get them to function more efficiently, we free up resources.
Yeah, yeah. So it's all about just making the system more efficient to
Yeah,
free up more energy so the brain can put that energy towards other things.
absolutely. Absolutely. Then I can remember to get up to my alarm and remember what underwear I'm supposed to wear for Thursday, so to speak, or whatever it is.
Yeah, it's kind of like, when they do these brain scans, and so when someone's learning a new song on the piano, it takes more brain energy, but once they've memorized that song, then they can play that song even better than they used to, but it actually takes less brain
Yeah.
power, and it's almost like in the case of someone with dysautonomia or concussion, they never get to that place where they can do the basic thing and their brain doesn't have to think about it. It's like they're always stuck in that beginner mode of the brain needing to utilize way more energy than it should to do all of these tasks throughout the day. And that's why they're so tired by, noon.
100%. The automatic stuff, the stuff that should be automatic doesn't become automatic and they struggle.
Mhm.
And that's what
Yeah.
we do when we do brain rehab is we help the automatic stuff become automatic again in a lot of ways.
Yeah. That's a good way to put it.
Yeah.
All right. What else you got?
What else do I have? Well, and you can layer, like you said, I like talking about layering things in where we can use visual mapping, we can use auditory mapping. I've layered in olfaction a lot as well. Again, this is something where I'm postulating offering a course on olfactory rehabilitation and traumatic brain injury and dysautonomia because it's a really fascinating, and again, as long as they're not allergic to like an essential oil or things you use, it's something that's very nice on a brain that is suffering from fuel delivery issues. To smell things is a lot easier than doing a fast eye movement or an anti-saccade or some of these things, and you can kind of prime the brain doing some of these relatively basic functions that don't take a lot of cognitive load. You get that brain to kind of go, "Oh, okay, I can handle a little stimulation. Now I can get some pupillary dilation and constriction like I'm supposed to. Now I can layer some of those other therapies in," where you might have taken 2 or 3 or 4 sessions to even be able to do that stuff before.
Mhm. Yeah. And so are there certain smells that seem to be uh I don't know, more gentle on the system or other like, have you had
Well,
people had kind of a paradoxical reaction or the opposite response you were looking for?
very, very rarely have I seen people struggle with olfaction, again, unless they were allergic to some kind of a component of the oil. If you're looking at olfactory research, you're gonna see eucalyptus, lemon, cloves, and rose. Those are the 4 scents they're looking at with any identification, all the COVID research, all the Parkinson's research. Those are the 4 basic oils that they'll use, or the 4 basic scents. You get into the upset testing and things like that, they expand on that, between 16 and 40. The human nose can smell a trillion different scents when it works well.
Wow, a
Yeah.
trillion.
Yeah, you would have thought that, right? Everybody says, "Oh, we don't
No.
smell anything." We smell tons of stuff when it works. So, it's really cool when you look at that. So, you can kinda do the same thing, like I said, with the colors that are close together. You can do the same thing with scents where it's like, "Can I distinguish between lemon and orange?" Or things like that. You can activate different parts of the brain with that. So you can kind of really bias your olfactory training based upon maybe what hemisphere you'd like to bias in your activation or stay away from in your activation by having them do different things.
Yeah, yeah. I remember, when I first started out and I was interning with Dr. Kemp, every single new TBI patient would come in and he would grab his vanilla
Yeah.
and he'd grab, like a lavender. And I remember being surprised at how many people he would like give some kind of floral scent to, and to them it smelled bad. It didn't
Yeah.
smell like flowers. And it just kind of struck me of, oh wow, I know he's got lavender under this person's nose and
Yeah.
they're saying it does not smell like floral scent at all, and really stood out to me just how common this response was to not being able not only identify smells appropriately, but like you were talking about with COVID, people were having those phantom cigarette smells.
Yeah,
I had patients with that too.
yeah.
And, just how fascinating the brain is when it starts mixing up things and misinterpreting smells and scents. And yeah.
Well, yeah, and they haven't had an injury necessarily at the cribriform plate where they can't smell that it would make a good thing smell bad. It's interesting, and I've got a new, kind of connection I've made in my clinic where I've got a mental health therapist who sees a lot of patients with functional neurological disorder. The olfaction is something that feeds really well into some of the brain hubs that's worked into, so we've started to work in, nice pleasant scents or pleasant perceived scents with functional neurological disorder patients. It's been pretty good so far. It's really interesting the impact you can do just with some essential oils. Again, more analog applications where you're not having to necessarily subscribe to a service to get a therapy or something like that. So some people are looking for that are clinicians and patients as well, I think.
Yeah, yeah. Well, and it just, points out just how three-dimensional, rehab really needs to be. It's not just, "Let's go sit on the computer and do Lumosity for 2 hours a day." It's like,
Which is, oh, what a
no.
drag, right? What a drag. You go, man. It's like I wanna go out and play pickleball or something.
Mhm. Right, yep, yep. We gotta have movement, we gotta have smells, we gotta have color distinctions, we've gotta have all the things, eye movements intact,
Yeah, all that stuff, exactly.
anterior neck muscles
You need
relaxed.
those bad boys, yeah, you want those relaxed but ready to go.
Mhm. Man, crazy.
Yeah. So those are things I've been working on and some developmental, maybe academia that's to come, and again, we're getting the word out there on this for patients as well. Absolutely. And this is I really appreciate you having me on and talking to me about this. It's just something I've become really fascinated with, and it's very clinically relevant.
Yeah, yeah. Well, I will look forward to your course when you put all that together and, start, sharing all that information with everybody else.
It'll be fun for sure.
Awesome. Well, why don't you tell people where they can find you?
I am located in practice in suburban Omaha, Nebraska at Advanced Chiropractic and Neurology. My website is www.omahaspinecare.com. We just revamped our website. It's really exciting. We've got some new things coming forward, working with a lot of any kind of patients out there. I am also assistant faculty at the Carrick Institute. So I do offer courses for practitioners as well through the Carrick Institute. I'm also out there with Cedric with Nerd Solutions.
Great.
Just trying to stay busy.
Yes, I'm sure you are.
Yeah, super
Love
fun.
it. Well, I will add all that, into the show notes, and once
Awesome.
again, thanks I know you're taking time out of your clinic day to come on the show, and so thanks for taking the time and being here today.
Always a pleasure. I appreciate you having me.